Dr. Ajit Mullasari is going to start his session with his talk on IVUS versus FFR in lesion assessment. Who is one to choose?
Thank you very much and good morning. And my job in the next 15 minutes is to talk about IVUS versus FFR for lesion assessment, which one to choose. So the important thing is, why is it important to diagnose ischemia-producing lesions? And FFR is really for the assessment of ischemia. There's always an anatomical functional disconnect, which we saw in the case yesterday evening. And it's also important that we treat our lesions optimally. Why is ischemia all that important? We know clearly that the annual risk of death is basically higher if you have ischemia on the spectalium as compared to a normal scenario where there is no ischemia. And also, the more the ischemia, the more likely that you're going to have clinical outcomes. And clearly, this is from the COURAGE nuclear sub-study, that if you have more than 5% ischemia, you can see that the event rates are almost doubling at 6 to 18 months. It's also important that if you treat your ischemia well, and you can see here clearly people who have had their ischemia treated well as compared to ischemia not treated well, means more than 5% reduction of ischemia, do better if the ischemia is treated well. So in patients with proven CAD and ischemia, alleviation of ischemia decreases death and myocardial infarction. So in a conclusion, patients with suspected CAD, the risk of death and MI is 10 times larger when ischemia is present. In patients with angiographically proven CAD, the risk of events is proportional to the extent of ischemia. If you alleviate your ischemia, you have decreased death and MI. And in patients with proven CAD without ischemia, annual death is very, very small and not improved by PCI. So functional information is paramount to optimize treatment with CAD. And the best way to assess functional ischemia is by a simple fractional flow reserve, which is basically, we all know this formula, is dependent of flows, distal versus proximal. What is the important characteristics of FFR? It has a well-defined normal value of 1 in all arteries, all patients. It's a well-defined ischemic threshold of 0.8. And we can always discuss what's the importance of 0.8 and 0.75. It takes into account collateral flow. It accounts for the extent of effective perfusion territory. It's extremely reproducible. It's not influenced by hemodynamic changes like blood pressure, heart rate, or contractility. It's valid in almost all clinical conditions except for a few, and lesion subsets is unsurpassed in spatial resolution. So the most important scenario where we use it very effectively is in a pre-surgical evaluation. So this is a 75-year-old male, circumflex stenosis looks borderline, and you can look at the FFR at peak adenosine is 0.82. You can safely send this patient for surgery without fixing the circumflex. The DIFFER study was an important study which evaluated 325 patients who were randomized with an FFR less than 0.75 and FFR more than 0.75. And in the patients who had less than 0.75, they had PCI performed. In patients who had more than 0.75, they had PTCA in some group of patients, which is called the perform group, and more than 0.75 who had angiographically significant looking stenosis, they were deferred the PTCA. And what happened very interestingly is the reference segment, that is FFRs less than 0.75, obviously had the highest events, but the performed PTCI who had FFRs more than 0.75 did worse than the patients who differed. So clearly, it's an important message to take home that if you have high FFRs, as more than 0.75, you can safely defer those patients from procedures. The other important situation is when you have multivessel disease, 72-year-old male, small NSTMI 3 weeks earlier. You can see there's a Circ lesion, LAD lesion, ramus lesion, and an RCA lesion. But you look at the LAD, it's 0.97. You look at the ramus, it's 0.90. You look at the circumflex, it's 0.48, and that's significant. And the right, 2 lesions are all 0.85. You only need to fix the circumflex, so a triple vessel disease becomes a single vessel disease. Anatomically versus functional coronary artery disease, if you have FFRs less than if you have angiographic stenosis of 90 to 99%, most often your FFRs are less than 0.8, while it's the other way so if your stenosis are between 50 to 70%. Now the FAME study was the first study, which was an important FFR study in patients with multivessel disease who had stenosis of more than 50%, who were amenable to stenting, were divided into two groups, the angiographic guided PCI versus the FFR guided PCI. The stenosis was measured in all FFRs, and those which had FFRs less than 0.8 were stented, while in the other angiographically looked at stenosis, all were stented. And there was a 1 to 5 year follow-up. And what it showed that you tended, when you had an angio-guided PCI, you tended to put more stents in patients, you tended to use more contrast, and your costs went up. More importantly, your myocardial infarction was higher in the angio-guided PCI, and your death and MI was also higher in the angio-guided PCI. 2-year survival was better. We were FFR guided as compared to angiographic guided, both at 360 and 730 days, and the symptoms were no different. The 2-year outcome of deferred lesions was very low. Only 1 out of 530 patients who were deferred on the FAME, that's 0.2, resulted in a late myocardial infarction. And at 2 years, only 1.9%, that less than 2%, progressed. So clearly by deferring patients by FFR, you did them good, and you did not create any great events at 2 years. It also improves not only your outcomes, but it improves your costs, and you save about $2,000 in the circulation article by doing an FFR-guided PCI. The FAME2 was the more recent study, which was basically FFR in all target lesions in multivessel disease who were DES stented, and there you had patients who were randomized with at least one stenosis of less than 0.8% to 1:1, that is PCI with optimal medical therapy versus optimal medical therapy. And when the FFRs were more than 0.8, they had optimal medical therapy and were put on a registry. And what it concluded, and this trial was halted because people who had FFRs less than 0.8 and who were not treated did poorly as compared to the other groups. So clearly, FFR is a very important tool to assess. The other area where it really helps is in bifurcation lesions. You have this PCI done to the LAD, a diagonal looking tight, but you look at the FFR 0.85, you don't need to do anything for these lesions. Don't even touch it with a balloon. Nothing happens to these lesions. FFRs less than 0.75, if you have more than 75% stenosis, your chance is about 30% that they will have FFRs less than 0.75. In left main disease, another very important scenario where you can use FFR very usefully. The left main ostium has a 60% stenosis. The MLA by IVUS is 4.4, but the FFR is 0.86. You can defer your PCI. Here's another angiogram where ostial left main looks 20%, but the LAD is a huge vessel. You look at the FFR, it's 0.70. You need to fix this lesion because this is an important vessel for this patient with the LAD being large. Interventional cardiologists are not very good at eyeballing left main stenosis. Only half of them have an inter-observer concordance. Clearly, if you differ left mains by FFR of more than 0.8 and you treat those with less than 0.8, your outcomes are exactly the same. So you don't need to worry. Once your FFRs are more than 0.8 in left main, please leave them alone. What is IVUS FFR correlation? Is there any correlation? 2 studies, one from the Sejong Park's group and one from Ben Doe's group, clearly showing that FFR and IVUS sort of comes close together of an FFR 0.75 at 2.8 and here at about 2.42. The lower your IVUS area for FFR, the sensitivity improves. The other important thing is if you do FFR guided PCI, you tend to do less PCI. And also that by doing less PCI, you don't harm the patients because they sort of behave similarly as patients who had IVUS-guided PCI. It's important to know the effect of downstream lesions, and it's very important that STEMI is not the right case to do an FFR. You should not do STEMI FFRs. You need to wait for about 5 days after STEMI to look at the lesion with FFR. But in a non-culprit vessel, in ST elevation or non-ST elevation MI, there is no problem. You can do your FFRs very, very well, and they are good. So then why do we need intravascular imaging? We need intravascular imaging for a few reasons. One, to look at the angiographic limitations and assess the anatomy, especially in left main stenosis, especially if you're not sure whether it's in the ostium of the left main, you're not very sure whether there's spasm, streaming of contrast, short length of vessels. We can make it out and pinpoint left main stenosis. We can look at the plaque characteristics, whether they're fibrous, calcific, plaque ruptures, thrombi, and thin fibrous atheroma, thin cap fibrous atheroma. It also tells us how the artery remodels, whether it's favorable or unfavorable, whether there's calcium or there is no calcium, whether the calcium is adventitial or it's in the intima. And importantly, In calcified lesions, I think IVUS has got a lot of importance, especially when you want to expand the stents. And clearly you can see at times that the stent is underexpanded and you can push it up with a high pressure balloon. So optimizing stents in terms of diameter, in terms of length, and in terms of getting the right area, it's important to use IVUS. We also use IVUS, very importantly, post-stenting to not only look for expansion, but to pick up dissection and geographic miss. Stent deposition is, as I said, very important. You use a additional high-pressure balloon after stent implantation, and you get much better areas once you do a high-pressure implantation. In bare metal areas, bare metal stents, you need about 6.5 square meters as the important area number to remember. And in DS, you need about 5 millimeter squares in non-left main vessels as a cutoff for a good result after stent implantation. It is also important to cover the lesion well, and this leads in a DS group of patients to lower stent thrombosis. So IVUS guided stenting helps in reducing stent thrombosis, and this is a beautiful article in European Heart Journal 2008. And in IVUS in bare metal stents reduces restenosis. It also reduces in DS, in certain studies, myocardial infarction and death. And this is the main compare registry which came from Sejong Park's unit, showing clearly that mortality was lower if you did it IVUS guided as compared to angiographic guided lesions. It's also important to know the evaluation of restenosis mechanisms, whether it's underexpanded or neointimal hyperplasia, and also for late stent malposition, which is known in DES. So in conclusion, ladies and gentlemen, when to use FFR, all intermediate lesions in stable patients when there is no definite matching ischemia on a non-invasive study. All side branch ostia, post-main branch stenting when the lesion looks more than 70% and you make a decision whether to fix it or not. Questionable non-culprit lesions in STEMI patients. Multivessel disease to triage, cabbage versus PCI, and to guide PCI to significant lesions only. In PCI, of multiple lesions in the same vessels. But you should not do it when you have left main stenosis with a proximal LAD or a culprit lesion of myocardial infarction. When do you use IVUS? It's for guiding your PCI, when angio is unclear as to anatomy and features, when you have intermediate and ostial left main stenosis, which you're not sure about. Important in stent thrombosis to know why did the stent thrombose, and in stent restenosis to know. So IVUS shows you the vessel, FFR measures the flow. Both tools provide specific and critically helpful information, and both should be optimally used. So you do an FFR guided revascularization and an IVUS guided optimization of the procedure. Thank you very much.
Thank you, Dr. Ajit, for a nice lecture. I think it's very clearly told that FFR is more useful in deciding whether the vessel needs interventions or not, whereas IVUS is the best for optimization and to see what is the inside story before putting the stent, to know the size and length of the stent. So I think that's the main difference. One is a physiological parameter, another is an anatomical parameter.